Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator. This is session number 194. We have a two-in-one case benefit for you today. You will watch two simultaneous topics, I think both of extreme guidance for you in your approach. One is going to be a bifurcation of a LAD and a diagonal, and along with that you will also watch probably a DCB of a diagonal branch. So these two topics, hopefully you'll learn a lot of tricks and tips and learn how to manage them. With this introduction, let me take you to the cath lab where Dr. Kinney and Dr. Sharma are standing by. Anu, Samin, good morning.
Good morning with our team here, and very happy to be the new strategy, which is quite a bit, as you mentioned, being done in Europe, but I think it's now just catching up based on many data that side branch do very well with a drug-coated balloon and stent may not be needed. With that note, we actually have our same, this case which we showed, long calcific LED, and then there is a moderate size, a small to moderate size diagonal, and myself, Dr. Kini, and then we have two fellows, Sophia and Bharat, and of course CVT, Naira, Asif, and our nurses, Eldina and Will, same, and of course imaging is Kiski. Imaging will be needed. Question is at what level. We'll look into it, and let me present our case. Let's show the slides, please. We start. This is our same target audience overview, accreditation, and key is that we are also still available to have your CME if you go into the case. The faculty disclosure, same, no change. And let's get to our commercial supports. They added on, maybe we have to add some more in the future. The very interesting thing which I wanted to share with you is the Mount Sinai with the US World News ranking has come to number 2, and that's such a remarkable thing which we all of course we are striving for, and finally we get to the number 2, say where we were before. As you can see here, these are the top 10 of the latest, came out 2 weeks ago, of the US World News ranking, with Cleveland Clinic, which was 30 years number 1, has now displaced to number 3. And this is how our journey is. We were started quite about 7-8 years ago with number 10, gradually ascended up to the 4, and now number 2. The national ranking. Now question is, why? What will require to us to get to number 1? Everywhere we were excellent, except 2 places. One was the patient experience, and second the expert opinion. And of course, these things we need to work on to get to the next level. With that great news, I really want to take a pride into it, and of course we are thankful to all the faculty and staff of Mount Sinai Fuster Heart, both surgery, cardiology and vascular, because it's all 3 combined. It's the cardiology, cardiac surgery and vascular surgery, all combined, which gives to this great number for becoming number 2 in the US World News. So this is remarkable, Samir, which is a great news was a few weeks ago.
Look, it's amazing. I also noticed that along with the drop of the Cleveland Clinic was also Cedar Sinai.
Yes.
And I remember speaking to them, and they were at number 4 and wanting to rise up. Only shows how extremely difficult it is and how much sustained QA processes you need to stay at the level.
That is true. As you said that going to number 2, yes, but then maintain it and then come up will be even more challenging, but we'll continue to have challenge. So this is the case number 194, with a 44-year-old patient who has angina and positive stress test, good risk factor control. We always present them, A1C, LDL, CRP, creatinine and EGFR, all good. Patient has some cardiac symptoms, had some treatment for testicular cancer. Since then, an echo is normal ejection fraction on good medical therapy. So patient had a 2-vessel disease of the RCA and multiple lesions of LAD diagonal, which will show, and good EF, had a stent in the RCA, and today, Anu, you want to show this now? Let's see the angiogram first. No, RCA, yeah. Good LV?
Yeah.
Yeah, it's a good LV function. Normal EDP was normal. This is where we are for the left system. Circ is okay. Diffuse LAD disease.
And the diagonal size is, what size is the diagonal, you think? You want to take a little better view of the diagonal? There is osteal disease of the diagonal.
That's
Two-
not the thing.
two
7
five,
French,
2 to 5.
there's a lot of damping in the left main.
So there is a mild left main disease, and if you need, many times we have to make a hole, side hole in the even 7 French guide.
No.
I would say in this case, if you need to, we can go with a 6 French. We don't need
that's
7
what I'm
French.
thinking.
We are not planning to put 2 stents. Goal will be modify the main vessel, and then also just the side branch, whether cutting balloon or so, and then do a drug coated balloon. So that is strategy, which is the bifurcate cutting balloon approach, which has been published. So this is, you can see a lot of disease in the diagonal. Only question is, what are the chances based on our definition criteria that will come up without stenting the diagonal?
So you're talking about the lower of the two diagonals, no? Because there are
Lower,
two diagonals.
Yeah. One very small, the real D2.
Right.
D2.
Right.
I know, what do you think that can we come out without? So clearly, DCB is good when you have stent-like results. Residual different, maybe still 30-40%, not zero, but no dissection and good flow. That's where the DCB comes in. So question is the DCB instead of stent only if you have a good results of your intervention.
Yeah, it's
So, Samin, there is a
95%
question,
percent
right?
stenosis, and the lesion length is about 20 millimeters. Right?
Yeah.
So based on your criteria, and there is mild to moderate calcium, it's likely we'll need a stent. There are two options: either do nothing, stent across, versus if you have to do something, if once you do modification, pre-dilation, you may end up with the stent.
All right.
Two questions, both coming from Dr. Nikhil Jha. Was mid-cab discussed and maybe only a lima?
Yeah, so that's a good point. So question is, I know the mid-cab, putting a lima bypass to both diagonal and LAD, and then of course the RCA, PCI we have done. Just want to let people know the hybrid trial. Hybrid trial basically was the lima to LAD and stents into other vessels. That was NIH-sponsored trial, and compared against multi-vessel stenting. And basically after 300 patients, the trial was stopped. One poor enrollment, and they found that there was no benefit. So therefore, I would say in this particular case, if a patient needed to go for bypass, 44-year-old, had RCA disease, could go for full bypass. Now, many people, the mid-cab, actually, they are doing also MICAS or so they call, that all 3 vessels with a minimally invasive, not sparing the ribs. And so that is one way. But I would say in this particular case, RCA stent has been done. We take care of the LAD and we re-stenose, then we can think about robotic, maybe lima to LAD. So that will be my approach. Yeah.
In a young patient, 44, I think Dr. Jha's point becomes more valid for a geographic region such as India.
Yeah, that's true. That's absolutely correct. Yes. So since it's a long lesion, so lesion has a high chance of restenosis, but knowing that we are not going to affect, we are not going to that D3, that's where the lima will be. So as long as we are before that, will not jeopardize this patient's future chances of very good bypass surgery, be it may robotic or mid-cap.
So the fact that there is an option of not putting a stent with probable use of DCB, does that make it more attractive for a younger patient?
I mean, that's one way. I mean, particularly in this case, if you want to just say it's the moderate plus calcium, you do a Rota and the stent avoid technique or no stent approach will not be a wrong also, as long as you are able to obtain a good result at 0. Now, as you know, these are all being studied in many numerous trials. We have been part of the solution, which is the sirolimus. Now we have the magic touch, also drug-coated balloon, both for small vessels as well as for ISR. So all those trials are ongoing to answer. Now, large vessel, I think everybody believes your DES should be the first strategy. Large basically means 3+ millimeter vessel. Less than that, this DCB strategy, particularly if you are able to obtain a stent, reasonable stent-like results. You'll never get a stent-like results with a balloon only, we know that. But as long as there is not a dissection and the lesion has opened up, it's reasonable to do a DCB, particularly if you're thinking about surgery. Now, in this particular case, I'll say a little different. Reason is that if you see the bypass, if ever patient will need a cabbage, the bypass will be done at about 3:30 p.m. 3:30 or at 3 o'clock position, right? 3 o'clock position. So good size there. We are not going to touch that. So this patient will be spared. And yes, good. The patient has no restenosis in 1-2 years, he definitely can defer or completely eliminate cabbage for the future.
So there's another question from Dr. Mahmood Al-Rais regarding the use of FFR guidance here.
Yeah. So this patient has, as we saw, very positive stress test. Now, a lot of people actually, after the DCB, they are doing the FFR and IFR just to see that the flow has become good and there is no dissection. Some people even do the imaging to see that there is not a significant dissection, and then go to the strategy of DCB. So those things will incorporate. As far as the I would say the need for FFR or IFR at the baseline is not there. Patient has a significant ischemia. We know that with this lesion, even you don't have a stress test, you know FFR will be positive. So tell us what is your plan. Now you have wired it with the run-through wire. Yeah.
Wiring the
balloon and stent.
Torque-free approach.
Okay. All right. So let's complete our presentation. Go to the presentation. Complete. So this basically is our 1 second. The plan is stage PCI of the calcified. Although calcium looks quite low now, do you want to decide based on the imaging, or you are happy? Yuski, what do you think?
Yeah, we can do. And if you want, we can also assess the left main because some dumping.
You're saying assess the left main with this.
I would avoid imaging.
Okay. Now, but in the end, maybe.
Okay.
Right? Okay. Good. Then, so that's our plan. So we thinking that not a rota needed because calcium is definitely much less angiographically because we are doing quite a bit. You know, now there are IVL trials. IVL trials are, you have to do imaging with the calcium has to be more than 180 degrees. And some of them have 270 degree unless you're angiographic tram track. So this case, actually now looking at it, I would not call it a severe calcium. It may be just a mild calcium in the proximal area. Is there definitely? See that? There is a one wall, so it will be a moderate calcium. Can we go to the fluoro again? 1 second. Yeah. You see that in the proximal part where there is a second diagonal is there. There is a calcium in the one wall of the artery, so it's not a severe calcium, moderate calcium.
There is almost a chorus for people wanting imaging, by the way.
Yeah, wait 1 second. Yeah, okay. So we are ready for imaging. Let's do it.
So what is imaging going to tell us?
That whether it's a moderate 180 or 180 minus or 180 plus calcium.
Okay, so
because studies have shown that once you get a 180 plus calcium, you should modify the plaque, that calcific plaque, by some technique besides just doing a high pressure balloon dilatation. So let me just finish my presentation and we'll go to this great educational discussion. So that is the plan with the DCB of the diagonal lesion, and based on the criteria of one vessel disease, this patient will fit in on 2 medical therapy and positive stress tests. Okay. All right, so let's take the vote, whether it will be a 180 degree calcium versus, go to the fluoro now, please.
180 plus or 180 minus?
Minus, yeah, that's it we are talking about. And less than 5 millimeter or more than 5 millimeter. Those trial wanted more than 5 millimeter and more than 180.
Okay.
Those are the DCB trial, our trials of our IVL.
Okay, look at it.
Would not.
There's no calcium and significant disease. It's not going further.
It's a more proximal part.
Yeah, I'm trying to go in, but
yeah, I see eccentric. Right? Yeah, there is calcium. There is calcium.
But, not even one quadrant.
No. Yeah. Why?
No, most of it is. Look at the calcium. It is between like 6.5.
Yeah, and it looks like a little bit protruding inside. Maybe you can call it calcified nodule. Not like 180 plus, but there is calcified nodule, eccentric calcified nodule in the proximal.
It's only one quadrant. Okay.
Yeah.
Less
No, but
balloon.
what about we proximal? But you're in the very proximal area only. You could not go a
You
little
don't know,
further.
it would not go further.
Yeah. So then, is it not to say that if it did not go further, it's by definition, all the trials have said that if you could not cross your imaging catheter, it's a severe calcium.
No, it's significant disease. That's what it is. It's a lot of plaque. You look at, go back to that. It is a lot of plaque, significant disease. That's why the IVUS is not going. It's
So you
not to
didn't
say
cross
with
the-
calcium itself.
We didn't record.
Didn't record anything. Let's go back in again.
What do you mean you didn't
We didn't do
record?
pullback.
You don't need to pull back.
No, we
Do
need to
manual
do pull back.
recording.
Yeah,
Okay,
we
go
can
back.
try.
Go back.
Yeah,
You're
yeah,
good. Flush.
Okay, let's do it again.
So, I mean, how about dilating with the small balloon and going back with the IVUS?
Once
Well,
you
I would
dilate your
just say if that's required, I would just go with the Rota.
Right.
But that's the one approach. You are right. You do at 1.5 or 2 a balloon, and then do the IVUS to understand. So if that is the difficulty in our lab, actually, it's a very simple message.
Okay.
You have
Yeah,
problem?
So now manual recording. We are recording.
Okay, recording.
Yep.
Okay, I'm doing manual.
Yep. Eccentric calcium. This is some septal.
Look at it. It's
Yeah,
just
here's
a lot
a-
of plaque burden, no calcium.
It's true. Proximal part doesn't have
Yeah.
much calcium.
It's all
Eccentric fibrous and deep calcium here.
Okay, where is the level of the D2?
Now the-
This is now we are proximally
yes.
to
Left
guide.
main, you're already
in the guide.
yeah,
Left
yeah, yeah.
And I saw also left main some plaque, but
Yeah,
it's
but
like not that
not
significant.
significant.
Yeah,
No.
correct. Yeah.
See 7.9.
So yeah, this is a like proximal left main. 1 second, 1 second.
Okay.
Yeah, like actually borderline.
Borderline 6. It's just 6 millimeter.
Yeah, plaque
6 or
burden
6.
53%. This is a proximal left main.
Yeah. So that's fine. So
Yep.
let's go to the proximal LAD at the level of the diagonal.
Sure.
Extreme degree of plaque.
Actually,
Look
this is the start of the pullback. I mean, not pullback, but the start of the.
Yeah, I
I've
think it
carried
is
it.
at the level of D2.
Yeah.
It would not go further down.
No, but I would say what harm in doing a 1.5 bar?
Yeah, it's true.
No,
Like slow sticking inside. This is a
Based on
eccentric.
imaging, it's 1 quadrant calcium.
Yeah, and a nodule.
And there's a nodule.
Yeah, nodule can respond to PTCA. The EYE, I was
No, but your trial,
telling the right thing.
tell us about nodule shock trial which you're trying to do. Let's get
Please,
a rotor
let's
wire.
not
Yeah, do the
get
rotor,
confused.
Let's get rotor wire. 1.5.
No, SS. If based on what you just mentioned, there's no indication for Rota here. Means it is 1 quadrant of calcium. Now you want to do Rota before diffuse plaque, that's a different story.
No, is
But
it a
when-
1 quadrant only or some places it's a 2 quadrant? Kiski, calcium wise.
Less than 2 quadrant, but we are not sure more distal because we didn't cross the tightest part.
You did not cross it.
Only the proximal part is less than 2 quadrant.
Yeah, yeah. Don't just do a balloon.
Yes. We are teaching what's the right thing. Now they wanted imaging, we did imaging. It's it's barely 1 quadrant calcium.
You want to
So
wire
based
the
on that-
diagonal now?
Oh,
Yeah, do the wire, the feeler wire and the diagonal because diagonal has to be taken care. The
Yeah,
young
that's-
person, you need to do.
Okay.
Yeah. All right.
So the
Change in
diagonal,
stent. Yeah.
diagonal may end up being a bigger vessel than what it looks.
Now there is a trial also. Let me remember the name. In a small vessel, we compare Rota versus PTCA, and we found lower incidence of dissection and bailout stenting in those back in 99. Reisman was the PI, I was the co-PI.
status?
No, status was the high. Status was the using the 1.8 high degrees. You maybe.
Some die. Yeah.
First time, Samin, knowing you in 41 years, have I known you to struggle with the name.
I know with that name. So I think we have. I'm using that maybe after many years.
And I think you will, before this case is over, you'll remember it.
Yeah. No, definitely will remember. Yes. And that was a trial for a small vessel comparing Rota versus and Mark Reisman with the PI.
So just to complete our discussion and benefit from the reviewer comments, one of the thoughts here is if hardware is not crossing, we should do rotablator.
Okay. Yep.
Okay.
So that is what our audience feels that way also.
Well, one of them, which is specifically Dr. Jha.
Good.
And
That's what we have been teaching it. Yes.
Mhm. Once again, I want to thank our viewers. Thank you for your comments, for your recommendations, very astute observations. Keep it going.
Okay. What balloon we have?
We have a 2530 balloon.
No, but if you're, this will have tough time to go. Anyway, let's see. The Rota did not go. I mean, sorry, IVAS did not go. Pull the wire
Okay,
back.
have the.
Went in. Okay. I don't know why IVAS would not go.
It's just so you see how the vessel is significant plaque there. So that's the reason. There. Look at how nicely it's
No, it's not open yet. It's now 12.
No,
14.
what I meant
now
is
it's open
at that
nicely. Yeah.
level, at that level was an issue for the IVAS to make a turn.
Okay, Floro, see
Significant
if it
plaque.
opened up at 14 atmosphere or no.
Yeah, good.
You want to go a
Nicely
little
opened.
distal?
No, you just said that's where we are placing the stent.
No, but there is
For
a
the future
disease
lima.
until like 2 p.m.
Okay, we'll go. I want to give me some dye. Normally,
Yeah, good. That's good. That's good.
go. No, don't dye. So we know.
Little die. Yeah.
Okay, go.
Okay. 12 atmosphere.
Okay, down. So we are not doing anything to the left vein, okay?
Yeah, no.
Then we come up to the proximal. Get us a diagonal 2-0. Need a long one, right?
Compliant or 2
Yeah, yeah.
No, there's no 30 2 Yeah,
20.
2 But do a compliant first. 20 compliant balloon.
Okay. Down. We can do the diag and then do the IVAS again.
Take a picture.
Oh, bah, look at the size of the LED.
Was a very underfilled vessel before.
Yeah.
Yeah, diag also may be a big one. But look at that. Really cracked open, right?
Yeah.
You want IVAS or just stent it? So
No, but let's open the diagonal first. No, there I think we just stent.
yeah.
We are going to use a new stent now.
Which
This
one?
time. Or
You don't have
Biotronic.
the length.
Or sure, but that's okay. It will require
48.
2 stents anyway. No, it will require 2 stents.
So I am, Samin, unaware of this balloon. I'm sure with your travels, the Aperta balloon. Now, what is the Aperta balloon? APERTA.
Aperta. No, maybe somebody can put in there.
Device. Can you check the device aid? Has Andrew made his appearance?
Pull your wire back.
Well, I'm inquiring our audience, and we'll find the answer.
This is 2 compliant 20, right?
Yes. Yeah.
And it
20.
crossed very nicely, yeah.
Okay, go.
Now here we're going to do
Go.
our technique. That is, first you go, crack the lesion, whatever required. Let's say 16, 18, 20. And then you go down to half. To basically purpose there is, now you have cracked the lesion, at a half pressure you are tacking it up. And then some people used to do oscillate. We did the trial called crack trial. That time we used to oscillate. Because that time using the good balloon results. And so now actually the oscillation has come back for the cutting balloon. So few of the trials have used for the cutting balloon oscillation. But here we just go to the medium pressure, leave it for about 90 seconds to get a good results.
Okay, look at the EKG changes.
Look at the ST elevations and so.
Can we show the
show the
ECG?
hemodynamics?
Yeah.
hemodynamics? Yeah.
Always.
Yeah, very significant.
So big diagonal. And it's not that it's occluding the LAD. Is it occluding LAD? No. Fluoro? Maybe part of that could be
Okay, come
occluding
down,
the LAD.
come
yeah.
down, come
Yeah, we are
down.
coming down now.
You know, there was also a little plaquing in the left main, maybe the guide catheter.
Yeah. And do here.
No, what I meant, the guide is outside. I don't
Yeah.
have it engaged at all. Yeah.
Mhm.
Okay, we went inside and let us see now. Significant disease.
Well,
You want to zero?
tolerating better now.
All, yeah.
No, again, starts the EKG.
The vessel is 3 millimeter or 2.5?
Actually, the approximately 2.5, like all the way approximately 3.5. I mean, start of the IVS catheter is a 2.5 vessel.
So let's put a 2.5.
2.530.
2.530. There's no longer than that? I
30.
actually
And then we
think
put that.
48
We have
may
two of
cover
them.
it.
Yeah, no, but that's okay. We need 2 stents here anyway. Let's
Okay.
take a picture after nitro. 1 second. Good.
Ready?
Yep.
Oh,
Dissection.
that's exactly what I said.
Yeah.
That when you have that bad disease,
Yeah. Yep.
not even dissection, could be
Yeah, a little hematoma.
hematoma, perforation.
Okay, now, but more important, let's go to the diagonal a little further because we have to put a long stent in the diagonal also. Now we have to change it to a mini crush. See that again?
I don't want to.
12 o'clock. No, at 12
that's
o'clock,
what I
lesion has
meant.
not been opened.
So this is Dr. I'm surprised it took him so many years to join us. Welcome Kaushal Chhatrapati. I
Oh, yes.
follow him often,
Awesome.
and he's
Yeah.
mentioned Aperta is a cutting balloon from Nipro.
Ah, okay.
It's quite good with good trackability. And
Oh, you see?
there is a
Bad
further
disease.
comment. It's scoring plus cutting in a
Okay,
same
open the
balloon.
2.5.
Ah,
2.530.
okay. No, but you need a, now, clearly, the strategy of the drug-coated balloon is out of the window now, because once you got the dissection, no longer the issue remain that can you do a DCB. DCB can be done when you have a good results, no dissection, because you're not comparing. Only goal is that can you avoid stenting. In this case, you cannot avoid stenting, so we are going to do a stent in the side branch first.
No. Why side branch?
The
We are going to do the distal.
Okay, 2. Okay, let's do,
Yeah.
First the distal, which is the 2.530, and then proximally we do a mini crush.
You mean distal LAD?
Yeah,
Yes.
or
Distal
mid
of
LAD.
the-
Yeah, exactly.
the
So mid
distal of the
LAD and
lesions,
proximal. So we'll call it a proximal LAD with a D2 bifurcation and mid LAD. So 3 lesions we are dealing with.
I was unaware of this company, Nipro. Is it?
No, Nipro is a lot of products available in India of the Nipro company.
It's European or?
No, I think Japanese.
Nipro.
And they have a
Japanese,
very
okay.
nice guideliner also.
Mhm.
Very nice guideliner, very soft and goes in.
Unsurprising. A lot of innovative technology does exist in Japan.
Yeah.
Very. I bet you they have improved our.
Some die. Yeah.
Good.
No, hold on. I'm bringing it back.
Two distal, no?
Yeah,
it?
I know. There's no space now. No, there's some dissection now.
Yeah.
You see that?
Yeah, that's fine.
Okay, go up.
Go up.
14. Okay, down. Go up again. Now, what is the, you have a 225?
Yep. 2 to 5.
00225, what length
Yeah.
you have?
Yeah, 2 to 518.
And then down. We need a 3O. Proximally was 3O.
3 or 20. Yeah, we have 3 or 20.
20 or 18?
18. 3 or 18. Yep.
Okay, ready?
Yep. Yeah, 2 to 5. What's like? There is a 2 to 5. Question is longer.
For the LAD?
Yeah, no. 2 to 5 for the diagonal. A lot of disease in the diagonal. It was long disease anyway. So this is good. Let's take this out. So question is, what is the 2 to 5 longer? 26? Yeah, I think 2 to 5, 26. And LAD, we can take a 3O.
But
18,
from
right?
where?
3O 18.
Proximal edge we never defined.
Yeah.
Up to the ostium. Okay.
Yep.
So far, it's been absolutely outstanding result in the LED.
LED, yeah.
Again, the damping of the pressure, I think once again it is the guide.
Oh, oh.
2 to 5 first.
Yeah, the side branch came out, I guess.
Okay, let's go.
Hold on,
diagonal.
hold on, hold on, hold on. Take us picture here so we know the length of the LED.
So
diag
here,
wire is
Samin,
out.
this is a very useful point. I cannot make out who's the physician. I just have
Cranial.
their Sabaton 100.
What's the 3/0 length you have? Okay.
DCB can be done if there is only type A to C dissection without symptoms and EKG changes and no hemodynamic changes. Of course, you're absolutely right.
Correct. Yeah. But as you know, this is not a type A. It definitely reaching to
More
type
toward
C.
C. Well, even probably more than that, actually.
Yeah. Go. So yes, so that is true. Type A, and if particularly if you want to do and you do hemodynamic IFR, FFR is good, and then it's a to be left. There is no question on that point, but not with this. This is definitely a reaching to A is just a interluminal filling, dissection or kind of shadow. The B, as you know, with the NHLBI, those definition, B is your dissection without diastasis. C is dissection with diastasis, which is right there. And D is your spiral dissection. E is your total occlusion. And F is your CTO. So those are the 6 gradings of dissection. No, 1 second. We may need a little more. Your cutting balloon. Get a 2.25 cutting balloon. No, but take it out. Not ready yet. 2.25 cutting balloon. So osteal still need a little extra work.
Right. And you'll, of course, stay away from that dissection.
Yeah, just ostium will do it, yes.
So my summary of this case so far is that the extent of disease has been quite impressive.
No, diagonal, we remember that's the question I asked,
In the
and
beginning.
which AK said very
I
likely is going to
predicted
do.
that it'll require
Because this is by every
stent.
criteria of the definition, where you are going to need 2 stents, and this is the classical case where you're going to need a 2 stent because long lesion, little angulated, some calcium, vessel size less than 2.5. So every feature and lesion stenosis more than 80. So everything was there. That this is the case going to need 2 stents. So this is not, we call it a bailout. This is a planned 2 stent approach. So we wanted to just do this DCB strategy in this case. If not the DCB, this case is clear cut, is planned 2 stent approach. So
Can we put the hemodynamics in the side and show the,
Go.
not IVUS, show the ceiling camera?
Good. That's it. Let me just go up now.
Okay, good. Okay, down.
16.
Good.
A little bit more. Yeah, good. Way too far.
Good here.
Yeah. And then you do ostium. Yeah, good.
Down. Okay.
Now that's where the cut your things are. Yeah, good.
Okay, go up here again. Good. Down. There was some calcium at the
level
ostium
of the diagonal.
which.
Okay, let's try the stent again. And it's the thinnest profile stent, the 60 micron. That's the best of it, or 0. And as you know, that only one stent which kind of became had a positive result compared to the Zynes, and in the bioflow trials, and that's our 0. And this is what we are using today. Okay, we are going back again. This is the 2.25, 26 millimeter stent for the side branch.
We have the 3 already.
Good. So that ostium needed a little bit cut. So we okay, leave it there. Good. Let's get it now.
You don't have the white? Always this is for the side branch.
Okay. 3020. Sorry,
That
18.
long?
No.
18. 3018.
Yeah. Yeah.
Can we show the mini crush?
Is
Non-left
he
main
there?
mini crush? Felipe?
No, but he is there. Andrew is there now.
Okay.
Samin, is Orsero made by Boston Scientific now?
No, it's a different company.
It's a Biotronic.
Biotronic.
Biotronic. Yeah.
First.
Yeah. It's a Biotronic, and it's now actually Biotronic has been taken up by what is the main parent company now? Teleflex. Yeah. Biotronic has been acquired by Teleflex.
Yeah,
And
that's Nikhil has written here, Orsero bought by Teleflex.
yeah. Yeah. Biotronic, yes.
So this is a little a note by Jeffrey Wilson. I think it got delayed in reaching us, catching up, but agree this should get IVUS first. I bet Rota not needed. Any calcium will not be thick and would be treated with balloon only. Also
ready, wait,
curious
take a
about
picture.
the left main.
Yeah. So all we had done.
All good
Yeah.
points and
Yeah,
covered
very good point.
in our previous discussion.
Yeah.
Good.
But
Hold
the
on,
diagonal
hold on,
goes
hold on.
inside
Yeah,
a
yeah,
little bit. Yeah.
Little bit too much. Yeah, mega crush here. Okay, now some dye.
Yeah, that's
Side
much
branch.
better.
Yes.
Good.
Yeah,
Okay.
much better.
Okay, diagonal going up.
Expansion of this stent is unbelievable. Look at the
You're
beautiful.
talking about the Orsero.
Yeah.
Yeah.
And that is
Yeah,
why
I
there was
think,
actually lower side branch closure and lower MI, very procedural MI in the trial.
The thin struts make so much difference and
Yeah.
trackability and such low profile.
Okay, some dye. And let me see if the LED.
Question
LED.
from multiple sources, Anu, will you stent the left main?
No.
No.
So good point.
Yes.
But because
Okay, some
the
dye.
lumen is 6 plus, we felt that
Some dye.
left main
Okay,
will not
good.
be needed.
Go up.
Yeah. The wire has come out. As you can see, the technique of the mini crush there.
It's being shown. Yes. Good.
16. And we are going to
The
do
non-left
overlap.
main. Yeah, good.
Let's
Get
go
down.
inside a little bit. And once you pull back the wire, keep the wire into the guide because you have to recross it.
And another question here has come, would you be performing a pot?
Yeah, so I think that's
Keep looking at the steps
good.
down. I mean, we say non-left main, we don't need it. Here is a 3O vessel, 3O stent.
And you are going to do a kissing. And kissing, since you are going to do kissing, remember that we do pot very often, but we have the paper in jack intervention.
No, we don't do often for non-left main.
No, means people do
Okay.
pot.
We means you're talking community.
People do, yeah, people do pot, but there is no scientific trial or basis. I would say that one definite data we have is in the left main, but other places, in pro pot trial and all, they all actually, and our data from our center, the kissing balloon gives you actually better lumen, more circular lumen and less eccentricity compared to the pot. So I think the pot is overrated, particularly in these cases where you will become like minus 20 millimeter or like 20% proximally. Let's take a picture and then we'll see.
Samin, would you say overrated or overused?
I mean,
Overused.
Yeah, overused. Over means everybody believes that.
No,
if
because
not
the
did
logic is correct, but for the right case, I think for the
left main.
Left main.
yeah, a lot of cases it's used for, it may not be needed. Anu, another question: do you use ProGlide for femoral cases?
Yes.
Yes, all of them.
Most of them. All the intervention are closed because the fellows, as soon as they start, this is a new group of fellows. They get full training. They have to do 25 cases, which everybody has got their certificate, and now they are doing it independently. Going in the circ. Okay, now what? I think the left main. Okay, now I'm in the, I advanced the, since the guide was not fully engaged. Okay.
Go further and then pull back. So that is one people believe that pot avoid that. Now we had seen sometime you cannot get a wire into the side branch. There at that time you'll bring a balloon and open at that level the struts. High pressure definitely will open your struts. Yeah. So now question is, you want to use 1.5 balloon first, or what do you want to do?
We have a 2O. Get us a 2O12 balloon.
No, we did not have 12. That was a long one.
No, open.
Yeah, new
one.
2 or 12 compliant.
And I'm telling you, the way the wire,
Yeah.
this is the first mini crush we are doing using this stent. So let us see if 2O12 balloon goes, or get us a high pressure balloon we have, 3O. We never opened.
No, we can take, no,
So
we have
let's
to have
take
3O
it
now.
because we may need to anchor.
Yeah.
Be ready with the
Yeah.
anchor. Let us have the anchor picture ready, Andrew.
Do this.
Anchor.
The 3O actually should have non-compliant 15 or 12.
I mean, the distal is 2.5.
Yeah. Yep.
Huh?
Good.
15,
Get
15.
15, yeah. 12 or 15, any one of them which is available. So now we are going with the 2O compliant balloon.
Will let us see if it will cross.
So more observations here. Would you feel that the onyx is better for bifurcation because the cells are bigger and easy to recross?
Yeah, so that is truly, so clearly of the onyx because of that hybrid approach. But the only question comes is, what about the restenosis? You know, of any, we actually do use onyx, and of course the earlier group of the onyx resolute when compared with the Xience has a slightly higher restenosis rate, but onyx clearly is more deliverable and getting to the branch. Yeah. So let's say what we are going to do now is the two technique. One, we are going to anchor it, the balloon in the main vessel.
A flurry of new viewers. I'd like to welcome all of you. And many good remarks, questions.
Don't want to know?
One of the questions which has been asked, I think somebody may have missed it also. What was the wire to recross the diagonal?
This is the same fielder wire which we had before. Now bring back at the level of the bifurcation. This is a 3O balloon. We are going to open the struts here now.
Okay, go up.
Yeah. So it's not truly pot, because what we are going to do is, it's pot basically means you are before the bifurcation. And it's not before the bifurcation, we are just opening the cells of your earlier 3O, which you do post dilatation. And now, since we open, I think should have been a little more proximal to open the cells.
No, we don't need.
Yeah, good here. Yeah, good. Yeah, let's open this.
Okay, good. Okay, down.
Yeah. Okay, let's see it now.
Okay, go up. Oh, go up here, anchor it again.
Okay. Moderate
low
pressure.
pressure,
Yeah,
yeah.
exactly. We have 6 atmosphere earlier. Same.
Okay.
So 2, yeah, went in now. Good.
What balloon was that?
2 or 12.
2 or 12.
So anchor, what I have noticed, I don't know if you have noticed it, Samir, down. When we used to use Promus a lot, Promus is done, the plant is done. We never used to struggle like this to recross and kiss with
Go
our,
back, this
you
one
can
also.
go back to other live cases and watch.
Yeah, good. Go up there.
Now ever since that
Side
is
branch.
done and we have all these other stents,
Go.
no matter
all
what
the,
you're seeing, yes.
all the R&D, all the engineers working
Don't
on
touch.
balloons and stents now work in structural heart.
That's it. Or
This
the
is a,
drug
this
coated.
is
No,
a
no, this
low
is-
low profit business for
Yeah.
No, this
for
is the stents. Stents have been the same. What I meant.
No, but
Oh,
not
you
doing
may
a new technology, not going further.
by
Yeah.
this time
Money.
we would have had
Money.
all sorts of AI guided stent development, and I think it's lacking so far behind. And just because there is no no profitability there, you make the best stent and it sells for $180.
That's it. Leave the LED balloon there. We can put a 2.5 now for the side branch. Just complete
You want to? Let's check it. If it looks good, we're done.
Total stagnation of the
Okay, let's
coronary.
get the. Okay, go. I think it looks good. Let's just
Everything
leave
looks
it alone.
wonderful.
Let's do the IVUS.
it. Okay.
Kiski, we are not doing IVUS of the side branch, okay?
Sure.
So
very
Samin,
important.
once
Yeah.
again, bringing in Dr. Jha back into his into the discussion, because he raises a good point. I think it may have been because of how we advertise this case. Could we have used the DCB for the diagonal?
No, but
I
how?
think we went through that
was
point.
the plan. Remember, that was the plan.
No, we
did a-
talked about the dissections and all that, and I think in conclusion he's thinking back, maybe sipping the coffee and thinking, look, could we have done it? Yeah, maybe.
No, means with
No.
that dissection? Oh, no. Every trial, no, we are in all the randomized trials we have done now, about 300 plus trials of the DCB. This case will be contraindicated. If you do it, they'll take you out of the trial. Because this case has a very high chance of occlusion, subacute occlusion later on. Look at the dissection. It's a C dissection. They'll not
Bordering
allow.
on a
Look at-
D, bordering
Yeah,
on a D.
D, yeah,
More question, any updates on the biotronic bioabsorbable scaffold?
Yeah, so I think the only bioabsorbable scaffold, the data basically are very solid on the bioadapter, which is the link, which is the link which disappear in 6 months and leave your stent now broken, so have a
We can start with
pulsatility of
It's
the
coming.
vessel.
Can
That's
we,
it.
yeah, okay.
So,
all
but
major-
but I think that
Yeah, good transition.
bioabsorbable stent have a long way to go.
Vessel.
Whether it's a magnesium carbide, that's a biotronic, and
Stent.
drug coated on that, biolimus.
Nice on the block. Yeah, left main
Okay,
again,
nice.
like around 6 point something.
Okay, good.
Yeah, it looks good. Just
Very
one
nice.
point, like distal part is kind of under expansion focally. We didn't see before this calcium, but this is like a distal part of the stent has area is like 3 point something.
Okay,
Kind
come
of-
to the proximal.
Yep, proximal, the lumen area is like 6, 7. And this is the level of the bifurcation.
Yes.
Like well modified, like a nose thrust here, and come more proximal. Actually, like slight malposition at the proximal edge.
Mm.
It's on the block. Like slightly malposition here. Yeah, 0.4.
Just the upper limit.
Yeah, but
Can you explain the definition of malopposition using the
So based on
IVUS criteria?
yeah, it's true. Based on actually OCT and more than 0.4, and the longitudinal length is like 1 millimeter. It's gonna be the major malposition. This is by IVUS 0.4,
It's 0.4.
Yeah,
That's
yeah.
it. Yeah.
and also it's on the plug. So and if you go more aggressive dilatation, it's a risk of the dissection.
Risk of dissection.
And
I agree.
actually, the stent is expanded. So most important is the stent expansion. There is slight malposition, but stent area is like 7.5. It's a good expansion. So I agree. We can.
I think
skip
we'll leave
it.
it alone.
Yep.
Okay. Let's see what the angiogram shows.
Kiski, next level imaging.
Ready?
Absolutely fantastic.
Look at that. Beautiful. Proximal edge is nice. Yeah, EKG is good. Left main looks, other than imaging, left main looks good. Okay, let's go low mag and be done with the. Andrew, did we figure out? Yeah, and do we have it in the device aid? No. It's okay. It's too
Where?
recent then. And where is that company from? Yeah. They're saying Japan. Okay, looks good.
But we need to post dilate or no?
There is a malopposition but does not fit the criteria. It is on the plaque, so if we go aggressive post dilation, there's a
Perforation?
risk.
Let's say what
Kiski-
the
I think we leave
imaging,
it alone.
what
Is-
Kiski saying.
A question for Kiski also here. Was there significant plaque burden at the proximal stent edge?
So it's not significant. It's also important. It's on the plug, and like this is AI calculated. The plug burden is like 44%. It's on the plug, but it's less than 50%. So it's an optimal result.
And very good lumen.
Yes, yes.
Then I think we are good.
Yeah,
Samin,
Yeah.
a question about the anti-platelet strategy for this patient.
Yeah. So until now, patient was on clopidogrel. I think it will be reasonable. Young person with a mini, crush technique that we change it to.
I know we have 3 stents. His PRU with Plavix is 157.
Yeah. So I think it's reasonable to give at least prasugrel for a short period, if not for you can de-escalate after 3 months. But this will be the good case. What we do is, since on clopidogrel, we'll give a load of 30 milligram prasugrel now, and then go to 10 milligram, 5 milligram after, because body weight is less than 100 kilo. So
Yeah,
we go with 100 kilo, not 65. 100 kilo less, and 3 or more stents. You give the 10 milligram. So in this particular case, 30 load now, because already on clopidogrel, and then we give 10 milligram for 1 month or 3 months, whichever you want to decide, and then go down to 5 milligram.
But what is risk factor modification? LDL is 51,
Yeah.
HDL is 27.
Yeah, which you cannot do anything about it. Everything else is very good. CRP, A1C, and everything for this patient.
He has
Okay,
to exercise
Yeah.
cardio.
Excellent angiographic results. Let's go to our complete the presentation. In this particular case, we started with the drug-coated balloon, but this is what happens. All the drug-coated balloon trials have shown that almost about anywhere from 5% to 25%, you'll not be able to do a drug-coated balloon. Even your strategy was that way. Because the case which we had, dissection, then you are going to put a stent. So what we are going to do today is some publication. We have multiple publications last 1 year. Every year we do present the data from Mount Sinai, our interventional database, and we are going to present some of these data, as you can see here, all from Mount Sinai, including the review of the month, which is differential outcome of PCI based on ethnicity. This is a very important paper, the PCI outcomes at 1 year in the 5 major race and ethnic subgroups. So first one is the impact of bleeding risk and inflammation. So published in JACC intervention, the whole idea was that we know that patients who have high bleeding risk, and these are our interventional database registry. From there, patients where we have the data on the CRP and bleeding criteria, which is the anemia, low the patient on the anticoagulation, all those blood dyscrasia and all those the factor which have been published, and it came up very clear cut. High bleeding risk versus no high bleeding risk, and then subdivided based on the CRP level of 3, less than 3 or more than 3. So high CRP defined as more than 3. Highest event happen, high bleeding risk and high CRP. Lowest event happen, no bleeding, no high bleeding risk and low CRP, and others are in between as shown here. Very important was there was no interaction between the high bleeding status and the CRP level. Also, we saw that clearly individual endpoints that high bleeding, high CRP had a bad outcome, which is the red bar. But more importantly, it did not correlate with any bleeding. As you can see here, whether CRP of 3 or less than 3 did not have, the bleeding was identical, as you can see here in this group of the patients. But yes, it was associated with a higher MACE rate. Now, that was in the bleeding risk patient. In the non-bleeding risk patient, clearly the CRP still have a high event rate, but bleeding was not associated. So basically what we learned is that HBR and CRP, there was CRP did not correlate with the bleeding, and particularly the patients with a lower high CRP have a similar bleeding as shown here in this subsequent data. Then the second publication was the inflammatory risk and clinical outcome according to polyvascular atherosclerotic disease in patient undergoing PCI. The patient has peripheral disease, carotid disease, and CAD. And then what about your CRP level in these cases? As you can see here, coronary artery disease with polyvascular disease of the brain, the vasculature peripheral versus patient, those who did not have peripheral, only coronary. So either coronary plus peripheral or coronary alone based on the CRP levels. As you can see here, there was independent association between elevated CRP and MACE in polyvascular disease, but not in individual without polyvascular disease. And therefore, this is actually graph showing very red is the polyvascular disease, blue, non-polyvascular disease, everything, the MACE, your all-cause mortality, although MI and TVR was not different, but I mean, actually all the factors are higher in the polyvascular disease compared to non-polyvascular. So key is the CRP is bad, particularly it's maybe it's because of CRP they have a polyvascular disease, or it's the vice versa, very tough to say. So this is what we got into our database. Another paper was the treatment of additional vessel during PCI of the left main. Majority of the cases of the left main, we say do the PCI of the left main, leave the other vessels for the future. And this is the data which we showed that left main with additional vessels. As you see in the patients, additional vessel was treated in 390 patients, and we found the outcome left main only, which was 479, and 390 patients left main plus additional vessel. Again, this was more subject, maybe selective bias. Not every case got it, but this was not a randomized, but overall showed that anytime you made a decision, left main with additional vessel outcome was identical, and individual endpoints are shown here. Of course, you do a little more additional vessel, you have a little higher TVR, but non-significant. But there was no difference in bleeding, stent thrombosis, and so as shown here in overall MACE. Then another big data was that there are some papers that if you have a vessel where there was a bypass, if you do intervene that vessel where there was a bypass compared to artery, or you can say innocent artery where there was no bypass. So this is the paper came out with complex native vessel PCI after bypass occlusion compared to patient with history of CABG, patient without history of CABG, and we excluded the lima. And so it was more of a non-LAD, and you can see here technical success was identical. Patients who have history of CABG, patient without history of CABG, native vessel was done, lima was excluded. Composite of the complications were identical, 30-day MACE was identical, MACE at 1 year was identical, no difference in stent thrombosis. So basically showing that with this day and age, we did have a higher rotablation use in the patients who have prior bypass occlusion compared to native, but overall the procedural outcome and clinical outcomes were not different and shown here. Then the other paper was rotational atherectomy with or without intravascular lithotripsy, but patient with heavily coronary calcium. And of course, we don't do every case with the rotatripsy approach, but we do a rota. And then some cases, as you see, about 10% in our database require rota plus IVL. But those cases where we did rota and the IVL rotatripsy outcomes were identical as shown here. This is the 30-day data in terms of angiographic complications in hospital MACE, bleeding, kidney injury, and so. And then this is actually Kiski published this paper in the Jack case report with we call it a massive coronary calcific nodule, where you use a step bar approach and then IVL. And this is basically showing Kiski is here. Kiski, you want to sum up your observation in this paper?
Actually, this is our CCC live case last year. And we did a multiple OCT proof, like actually the full proof, and like a precise lesion assessment, and like step by step how we do loader and step up loader and the IVL, and finally like a great stent expansion. So it's a very great case.
Okay, can we define what is massive?
Yeah, so this is like, yeah. Kind of it's not defined when, but it's like we can show it, like you can see the
more than 90-degree arc. So you have what is called a calcium plate, and then your nodule is more than 90-degree arc. That we call as massive.
Beautiful.
And it's rare to find massive.
Yeah. Yeah,
Usually
90,
when a
90
majority
degree
of the
arc is
nodules,
very important,
yeah,
different.
what I meant is nodules are smaller than a 90 degree.
Of course. Usually they are like barely 20 degrees or 30 degrees.
Yeah, not
Then
just
we have last paper in the BMJ, a predictor of post-procedure troponin increase in patient undergoing elective PCI. And it basically goes with the, whatever definition you use is usually clinical factors and angiographic factors that which patient should have troponin elevation so that you can strategize which patient should be observed versus discharged home. And so in conclusion, there are patient-specific angiographic and clinical risk factors that can predict positive troponin. These risk factors should be considered in formulating more individualized risk assessment for those undergoing elective PCI. Then our focus review of the month was differential outcome of PCI based on ethnicity. So clearly, we know that overall studies have multiple papers have come which showed the South Asians have a higher CAD risk the risk factors, but more importantly, bad outcome of the CAD. But nobody had looked into it. What are the long-term outcome after the PCI in these various ethnic subgroups? So this is where we did 21,000 patients, with the white being 10,000, black 2,400, Hispanic 3,800, South Asian, because we have a big, our Indian population, majority of them were 4,400, and East Asian like China, Japan, a small number. But just to say, large number of South Asian patients were represented in this very complex graph, but a lot of work done in terms of the risk factors assessment. It turns out to be the risk factor were not really, except the LDL, HDL, which was shown earlier. I know also that those have lower HDL. The other risk factor in terms of the smoking is not there. Diabetes slightly higher, and presentation, more acute presentation. But clearly the Indians, South Asians will wait till they have symptoms. But yes, once they do follow very clearly, and of course the treatment differences were not there. Medical compliance was very good, and overall shown here is the 1 year cumulative incidence of cardiovascular events following PCI in various population in terms of the death, stroke, MI, and target vessel, which puts it together very nicely in this. As you can see, all-cause death, which is the South Asian first time showed after PCI, you have a lower death rate, you have a lower stroke rate, lower overall MACE, and highest was in the black population. The question was that why that happened. It's the various, we actually found the socio-economic status that did not make a difference. The zip code did not make a difference. It basically was that South Asians, once they are treated, they actually follow compliance and frequent medical visits, and that led to the such a good outcome. So significant racial and ethnic disparities exist in 1 year PCI outcomes, with South Asian patients exhibiting favorable outcome compared with the white patient, and black patients experiencing the worst outcome. This is the first time ever shown the South Asian has a better outcome than their other competitors. Baseline comorbidities and estimated risk factor do not fully explain these disparities, suggesting that targeted strategies are needed to address the multifactorial influence on PCI outcome across racial and ethnic groups. So with that note, I'll just complete our presentation. Elevated CRP associated with increased MACE, but no increase in bleeding after PCI. With good understanding now. Elevated CRP associated with increased MACE only in polyvessel disease. Then left main PCI with additional vessel is good. Does not increase MACE, so could be done. PCI of native vessel has similar MACE to the vessel with SVG occlusion. Another good observation we had. Rotatripsy is safe and has similar MACE to RA in heavily calcified lesion. Particularly the cases which were done, we have the case controlled. Then patient-specific clinical and angiographic factor can predict troponin increase in chronic or coronary disease PCI. Then, contrary to numerous published reports of higher cardiac events in South Asian patients, a recent recent analysis of a large Mount Sinai Hospital International database reported favorable outcome and lower MACE rates after PCI at 1 year in South Asian compared to other groups, and the difference is likely because of the baseline comorbid condition, and one of the important factors is younger age. The South Asian presented at a younger age and has a better follow-up. So clearly, wherever you want to work on it, you have to have the specific treatment strategy. So 3 questions following the wrong statement regarding the interplay of high bleeding risk patient with high CRP level, lowest MACE in patient with no high bleeding risk and low CRP, lower MACE in patient with no high bleeding risk and high CRP, highest MACE in patient with high bleeding risk and high CRP, higher bleeding rates with higher CRP levels, and no interplay between high bleeding risk status and high CRP. Clearly, we know that there were bleeding rates were not different in patients with the CRP. So that's a wrong statement. Second question, following are the true statement regarding the results of PCI in native vessel with or without cabbage, except similar MACE rate, similar technical success, similar MACE rate, similar composite complication, and higher stent thrombosis 30 days. Wrong answer is E, that no higher thrombosis was similar. The third question, the recent report of 1-year PCI outcome based on race and ethnicity revealed the following except highest MACE in black patient, highest MACE in South Asian patient versus other, lower MI in South Asian patients versus other, lower death in South Asian patients versus other, lower stroke in South Asian patients versus other. Answer there is B. Highest MACE in South Asian, no. It was the lowest MACE after PCI in South Asian patient compared to others. With that note, I conclude my presentation.
Samin, excellent presentation. I wonder if race and ethnicity in your pretty large database was interrogated with the AI algorithms, would it show something different? It's a possibility. We've done some work on this from Sao Paulo looking at air pollution, and we found out it was humidity which surprised us and not the AQI or even the PM 2.5. So it has an ability to search out things which are inapparent by our existing protocols. Outstanding case. Otherwise, I'm truly, I think for me, the great experience was having in one single case, we had something like 5 or 6 new viewers whom I all welcome. Thank you all for your excellent comments. Samin, there is a question which has been posed by an individual physician with a very clear prompt that I'm sorry, this was meant more for a structural case, but the question is, could we use a tri-clip for Epstein's?
No, we are not using any because of the situation. The leaflets are totally different. So we actually had a few cases of Epstein over the years, and they were not appropriate for tri-clip. Now, could they be appropriate for Evoke, which is the TTVR? Is a different story. I think that maybe, but definitely not for the tri-clip. And just to say your AI algorithm, and now you're working on the AI with Anu, and we are working on a lot of the AI factors is the analysis of the database with the AI. I think more publications will come in that regard in the years to come.
Wonderful. Anu, any final comments from you?
No, I think we went through all the steps, especially when to use when to use imaging and when to do PCI without imaging. And a lot of importance is being paid for imaging is important for people to learn also how to do PCI without imaging using their eyes, EYE.
Yeah.
Excellent case, great teaching points. We conclude here and we'll see you next time on September 16th.